Hello, and welcome to Put Into Practice, the podcast for the JCO Oncology Practice. I'm Dr. Fumiko Chino, an associate professor in radiation oncology at MD Anderson Cancer Center with a research focus on access, affordability, and equity. State and federal policymakers make decisions every day that directly influence patient care and the research that drives cancer treatment. Oncologists are uniquely qualified to communicate with state legislatures and the U.S. government about effective policies for providing the best quality care. ASCO offers multiple ways for oncologists to engage and educate lawmakers on key advocacy priorities, from supporting clinical research, enhancing patient access and affordability, to supporting the delivery and infrastructure of cancer care in the United States. I'm happy to speak to a guest today about advocacy oncology with a focus on what community oncologists can do to safeguard high-quality, patient-centered care. Dr. Leslie Busby, MD, is a hematology and medical oncologist practicing in Rocky Mountain Cancer Centers in Boulder, Colorado, and the Chief Medical Officer of the U.S. Oncology Network. Over the years, he has been RMCC's medical director, and prior to being named CMO, was extensively involved with the network's Pharmacy and Therapeutics Committee. He is the first author of Importance of Physician Advocacy in the Fight to Protect Local Cancer Care, which was recently published in JCO OP as part of the special series focused on the Business of Oncology Practice. Our full disclosures are available in the transcript of this episode, and we have already agreed to go by our first names for the podcast today. Before we discuss your leadership roles within the U.S. Oncology Network and your recent piece on community advocacy, can you tell me a little bit about yourself? For example, from your bio, I know that you did medical school in Reno, Nevada, and residency in Kansas City, Missouri. I'm curious if you've always wanted to focus on community oncology.
Yeah, I look at it more as a journey. When I went into medical school, I was pretty convinced that I was going to go back to my home state of Montana to become a primary care physician. But through my education and as I progressed through training, I fell in love with oncology and hematology, really loved the complexity, the ongoing science. Just when I thought I could forget some of those pathways in medical school, they come back with a new therapy that makes me go back and look at it again. And these incredible therapies are just amazing. And then, most importantly, I really enjoyed helping people at their most stressful situation in their lives. And that's always been very beneficial to me as well. I get a lot out of that.
From your Rocky Mountain bio, you said, I believe that most patients get overall better care when treated by physicians who live and work in the same community. Can you discuss a bit on what you feel are the benefits for patients for high-quality, community-based oncology?
Yeah, I think a lot of it is we're living in the same communities as our patients. Our kids are often going to the same schools. Where I had the pleasure of working in Boulder, Colorado, there was also a community hospital there. I remember one of my colleagues saying that it was small enough that you knew most of the other physicians that were working there, but large enough that you could do some interesting things. I also, as an example where I practice, we collaborate quite a bit with the University of Colorado down at Anschutz, but it's a 45-minute drive for our patients. And probably for 80% of the therapies out there, they're standard therapies that we give day in and day out, where I find the university very beneficial as young people with cancers that are really interested in studies we don't have availability to, or really rare, unusual diseases. That's where it becomes very helpful in that. But then we can also, by collaborating with them, I've had patients go to MD Anderson, Mayo Clinic, we can bring them home and treat them and help take care of them. Because if they're treated elsewhere and they get sick, where do they end up? They end up in our ER, and we can take care of them as well. So,
yeah, I really appreciate this idea of shared care for medically complex patients, but that also the best care for patients often means being able to deliver it closer to home within their own support network. And again, knowing the community and knowing what the resources are there, I think it just makes such a huge difference. It's hilarious. Sometimes at MD Anderson, I'm a radiation doctor, so as you know, it's a daily treatment. And sometimes I'm actually being like, please, you should actually get this closer to home. I'm not trying to insult you, but you're not that complex. And the quality of life that you will have being able to, sleep in your own bed and, to see your family every day is not going to be eclipsed by whatever bell or whistle that I have the capacity to deliver here.
I agree. And especially radiation, where it's gotten better, but like 6 weeks of a kind of a grind, a daily grind, being able to be close to home where your family can bring you back and forth to the clinic every day. Because most patients do fine day by day, but it starts to wear on them after a while.
Absolutely. Whenever I talk to medical students, I also try to really emphasize 80% of care in the United States is not done in academic medical centers. We need active and motivated and engaged physicians in the community because you guys are doing the vast majority of the work of curing cancer in the United States.
And it's interesting you point that out because when you do talk to people on public policy, if you were to ask them where most of the oncology care occurs, I think they would flip it the other way, that 80% is at the major institutions. And we have to educate them that that's not the case. The vast majority of patients are just treated in the communities. But both are incredibly important in providing cancer care in this country.
Absolutely. And I think protecting access and care at community cancer centers really does serve everyone in the United States. Piggybacking on that, I know that you transitioned to a new role of Chief Medical Officer at the U.S. Oncology Network as of July of last year. So presumably that means that you had to step back a bit from direct patient care. Do you mind talking about your transition into leadership, what you do in your current role, and how you balance the priorities of an organization that is truly vast, spans over, looks like 700 treatment locations, over 3,000 providers? It's real big.
Yeah, it wasn't easy because I had to cut back by more than 75% of a patient care. And I really appreciate my partners had to dole out some of my patients and they took over those patient care. And my nurse practitioner really helped me out in that transition as well. But it takes a while, even when everybody's ready for it, it takes some time to spread that over. And you miss some of that daily camaraderie, just talking in the halls. Still there once a week, but it's not quite the same. I don't feel quite as involved in that specific clinic. And I've been interested in things like plasma cell dyscrasias, so I did keep a lot of those patients. Somehow I developed the reputation of being the local coag expert in town, which is great. I help out my internal medicine docs in town and the surgeons with their questions. But I had to give up a lot of day-to-day oncology care. I used to do a lot of head and neck, and I just felt I couldn't provide them what they needed. But CMO duties is interesting. When my kids ask me, like, what do you do all day? And it's like, well, there's a lot of meetings. But I kind of look at it, kind of broke it up into maybe 3 areas. In one form, I'm an advocate for physicians, for their practices, to the network administration, if you will, so they understand what the physicians are going through, their experience, what the practices are looking at. Nothing drives me more crazy if someone says with the HR, oh, just be a few more clicks. If you say that, they're going to be very angry. So if you say, we'll take away 3 clicks for you to do 1 click, they're really happy. Also help with them, the group develop long-term strategy. For example, how are we going to incorporate AI into the EHR, things like that. And then sometimes have to point out uncomfortable truths when it comes to quality, our performance. Could we doing better? One of the things on my mind has been succession planning. That's a big thing with a lot of these practices, is that they've got great people at the top, but how do we find that next person that maybe 5-10 years from now can take over? And of course, technology is always such a big change. I also help facilitate try to line incentives going forward, but also almost like an interpreter between the physicians and the practices and the network. So I can explain to the network how the docs are thinking, but sometimes I'm having to go back to the physicians and the practices and talk about trade-offs and why we can't do what they would really like us to do, because sometimes it's against the law. And I try to explain that to them. You learn a lot really fast. And then my goals, I'd like to remove the barriers from the physicians and then the other clinicians and staff. We want to continue to improve on quality of care, provide high quality care, and then preparing for the future, CAR-T, bispecifics, radiopharm, all these great, incredible therapies that are down the road.
Sounds like pretty scoping in terms of what you do. How do you actually find that balance of still seeing some patients in clinic, but then again, I'm assuming just traveling and just so many meetings?
Yeah, it helps to have a good nurse practitioner that helps you out right away and can feel comfortable to reach out and contact me when there's a problem, or take care of most of it. It's still something, though, I may be traveling, but usually once a day or every other day, I'm getting into the HR or returning phone calls or what have you. So it's a little bit of well, I don't want to say burden, because I do think it helps me stay connected. When a physician gets out of patient care too much, they sort of lose touch of what it's like to be a day-to-day physician. And then over time, it's harder for them to connect, and the physicians feel like you understand what they're going through. So I think it's very important, and definitely people in the US Oncology have been very supportive of that as well.
But you're saying even as chief medical officer, you still have to go back and answer questions from the patient portal?
Yes. Yeah. A lot of the patients know that I've taken on this job, and they'll ask me about it when I see them in clinic, but it still doesn't stop them from, I need a refill on my medications. I need to do this. I want you to call me if I have a question. That, just like everybody else, just a lot fewer patients that I have to do it over than I used to.
Patient messaging is the great equalizer, is what you're saying.
Oh.
And dealing with the EMR.
That's right.
Is the great equalizer.
That's right.
Now, in your recent JCO OP piece, you highlighted that, and I quote, behind every regulation or reimbursement policy is a patient whose care is being shaped by forces outside of the exam room. In your opinion, what are the top policy issues that are directly impacting patient care today, and how do they actually impact community oncologists differently than those in academic centers?
Yeah, I think a big factor that comes in all the time is wrapped around reimbursement. As you know, each year there's this recalculation of the formula, how it's reimbursed, and it always seems like we're asked to do more and more for the same or less each year. So as for community versus academic, that aspect, one of the frustrations has been how, say, like Medicare calculates its reimbursement formula for similar activities, say an hour of nursing time. And over the years, it's gone to about a 2 to 3 times the reimbursement than what we would get. And when you talk to public policy people, like, well, that doesn't make any sense. I'm like, that's our position as well. It's just how the system is set up. So we have to continually bring that to the forefront. There's also differences if you're a for-profit versus a nonprofit entity. Nonprofits have different ways they can raise money. There's a lot of assistance out there to help kind of clear bad debt. There's more assistance out there to help take care of some of those either under or uninsured patients that many times we can't tap into. For example, we don't limit Medicaid in Colorado, and most of the practices I talk to don't either. They feel like it's an important part of what we do. But for most people I talk to, you lose a little bit of money every time you see a Medicaid patient. And, we prefer at least to be able to break even and trying to take care of patients who are on Medicaid. Other differences, there's not the concept of, in academics, we might have protected time to do your research. We have a lot of docs that do a lot of research, but it's sort of has to be a part of their day. It's on their time to do that. Although we don't have the stressors that academics have of raising money and those sorts of things, and then all the teaching that you do. I do think academic centers probably have a lot more leverage when it comes to dealing with payers and PBMs. Many times, payers' customers want to have a major academic center as an option. So they're willing to allow much higher reimbursement in those centers where we have to kind of continue to fight. So I think those are some of the big items. Hospital systems, I'm a little biased. I really enjoy having my own practice. We own our own practice. We get to make the decisions. It's our own business rather than being part of a hospital where someone else is doing a lot of that. Talk to people, they don't have the same influence, if you will. And I just often don't feel they have the same expertise when it comes to like billing and that sort of thing. So they're not quite as efficient, especially medical oncology. But like I said at the beginning, I'm a little biased about my position there.
I'm curious about your thoughts about prioritization amongst, for example, academic versus community centers. I know that many academic centers have a very well-oiled machine, and they have invested a lot of staff members into it. And within the community, I would imagine that it's actually quite more challenging and that you might not be able to kind of take it to the mat with every single case. But I would love to hear your thoughts about that, because that's a direct policy thing that I think is hurting everyone, but potentially community practices worse.
And definitely on this new position, a lot of discussions always around revenue cycle, the prior auth, and then on the back end. In general, most of our practices are very successful at getting reimbursed. Where things are more or less successful depends on how much emphasis you put on things. So you can have a system set up that you won't give any treatment until the prior auth is complete. But like you said, we might do it a lot more efficiently. There may be one person, so sometimes it takes a little bit longer. We rely a lot on our APPs, nurse practitioners, physician assistants, to help with like peer-to-peer. And I have found that using such tools such as open evidence really does help write that letter when you need to try to go through that next step. But it's a burden everywhere. Probably the physicians get more involved. I'm guessing, I'm not sure at the academic, but usually we're actually asked to talk to the payer or our APP or write letters to go along. It's more of an issue, though, when you really are going outside of the norm. And I mean, one of the things at an academic center is that you're often not seeing the norm. If you wouldn't need to be there if you were seeing the norm all the time. So in other respects, that could be a lot more difficult. I do remember sending a patient to MD Anderson for a very rare tumor, and they gave me a recommendation of therapy. And I asked, do you have something to support that? Because I'm going to have to get it paid for. And they're like, oh, yeah, I forgot about that part. So great recommendation. And it took a little bit, but I did get it paid for with their help.
Nice. Now, your piece highlights that community physicians can get involved at federal, state, and local levels. And this is a wide range of activities, from testifying before Congress all the way to writing a letter to your local newspaper. In your opinion, where should people start? I mean, you don't start immediately testifying in front of Congress, I'm assuming.
That's right.
How can oncologists really develop those skills for advocacy efforts?
Start simple by just either getting involved with your local PAC or with PACs associated, like with ASCO or COA is another one that has a very strong PAC. Starting to read their papers, listening to their updates, understanding the issues that's going on. I think also it helps to start locally. One of the place that's really underused across the country, I think, is going to your local chamber of commerce. You are a small business, you're in the community. For whatever reason, we don't necessarily picture ourselves that way, but it's a great way to know the people in and around your community. The hospital usually, all the hospitals in your community usually send somebody to there as well. So it's good to make sure that you have your voice speaking up. Another easy way is also get to know your state rep, whether it's the state rep for your clinic or your local state rep or both. I found that often they're a lot more, should we say, less intimidating, more down to earth. They basically, you're often your neighbor. Even in a big city, it's not that difficult to get to know you. They usually want to know their constituents quite a bit and what's going on. They're really open to come and visit your clinic. And I find it's a great way to just kind of talk to them. And many times you might, if you develop a really good relationship, you might actually have more influence with someone like that than at the federal level, where there's a lot more people involved. But it's also a great way to just get started without even really traveling far from home. The next level up is work with administrative departments, whether your state Department of Insurance or what have you, and your board, state boards, and those sorts of things, understand what's going on. And even at the federal with CMS, they just put out their OPPS updates. That's the Outpatient Physician Payment Program. And they're looking for comments. And you don't have to jump into comments, but you can start participating in things like ASCO. What comments are they putting in there? ASH, what comments are they putting out there? And COA. So it's a great way to kind of see and where it's going through. And you can even write your own if you want. While they may not read every piece of paper that comes through, they do pay attention of things that are coming through there, how many people are commenting. It's usually thousands.
And you've mentioned COA a couple times. Do you mind, just for our listeners who aren't aware, what COA is?
Yeah, it's a Community Oncology Alliance. So they are a consortium of community oncology practices from across the country. And they have a relatively large board, very diverse. Right now, the president's Dr. Deborah Patt from Texas Oncology. But they're very active on the public policy side as well.
You give a couple of examples in your piece about advocacy success stories. Do you mind sharing a real-world example of some campaigns that you feel like really made a difference?
Probably the one on average has been the most successful has been white bagging legislation. So that would be to get a law passed where a PBM or payer could not require, say, an oncology clinic to do white bagging. If you don't know what white bagging is when the drug comes from a specialty pharmacy owned usually by the PBM or payer to your clinic. We've been successful in a lot of the states we're active in, such as Virginia, Texas, and Florida, with getting legislation passed. I testified twice in front of committees, which usually don't testify through the whole group. It's usually a committee. And when they say you only have 2 minutes, you really only have 2 minutes. So it makes you narrow your speech very quickly. We worked behind the scenes. We made some compromises. When it finally went to out of committee and to a vote, one of the houses passed it unanimously. The other one just had one vote in dissent. So nearly unanimous vote out of the Colorado legislature. But when it went to the governor, it was vetoed. It was a little frustrating because his reasoning was he was concerned about upcharging. And even though we had in there that we couldn't charge more than our negotiated rate with the payer, there seemed to be this fundamental misunderstanding about how that is developed. And there was this concern, and nothing that we could do could get past that bias he had. And there was also, they wanted us to not get paid more than what the payer paid their specialty pharmacy, which is fascinating because, number one, that's not public information. I have no idea what they're paying their specialty pharmacy. And number two, we know from other court cases that they sometimes play games with spread pricing and that sort of thing. So it didn't pass in Colorado. Our governor's term limited. So when we get a new governor, it's probably something we're going to try again. And I think that's an important thing about this is that it's not short term. It's the long game to get it done. Nationally, we've had some really good success when, I don't know if you remember the Part B demonstration program several years ago during the first Trump administration. A lot of people worked very hard to get that pushed off because that would have destroyed the whole business. I talked earlier about what we call site neutrality. We've been talking to Congress for a long, long time about that. We're starting to see that they agree that an hour nursing time should get paid the same, and whether you're owned by MD Anderson or you're owned by me. And then being able to mail drugs to the patients, I think that's a patient care issue. That we're able to keep patients on drugs longer, and I think they do better. It is a burden to make the patient always come in for the refill, especially on a drug they've been on for a long time. We've had some really good support out of Congress. We just haven't gotten it over the finish line yet. The U.S. Congress, everything just takes longer, and you just have to be patient and build those relationships. And that's what's really critical. It just takes time to build those relationships, get to know them, and give some advice when you're going to talk to people. You want to build trust, so don't ever lie. But you also want to be there and available for if they have a question or concern, they reach out to you. So if you build that trust, they will start to reach out to you because sometimes nothing seems to happen for a long time. Then something happens all at once. And you have to get yourself prepared for when that major issue shows up.
You're building up momentum towards something, essentially. And so these efforts are not wasted, even if it was not immediately successful. I kind of love that takeaway message. I feel like that's very valid in many different reflections of essentially you make an investment towards, honestly, anything in policy. It's going to take months, years, or even decades to actually come to fruition. And that may include multiple administration changes, as you previously mentioned, which is there's maybe a new person coming on board that would be maybe more sympathetic, and it's just chipping away at it.
That's right, chipping away at it. But there's a lot of education that goes involved.
Absolutely. Any last thoughts for how oncologists can, lead from where they stand? I know that a lot of people worry that small actions, things like emails, phone calls, won't really make a difference. But again, I think that they can really contribute to this concept of building momentum and creating meaningful change. Any last thoughts or encouragements from you?
Yeah, a couple come to mind. Definitely like writing letters if there's something you want your congressman to support. Again, they may not read every single letter. Their staff keeps track of how many letters are coming in on a topic and where they are trending. So the more you can garner support on something and push through, the more they pay attention to it. They do look at that. The other is sometimes I've had colleagues say, well, I don't know anything about it. I'm uncomfortable with doing that. Lobbying is a 4-letter word or something like that. But what I tell them is half of your patients are covered by a major government program. So I'm going to use a line from one of my Texas colleagues, Dr. Paulson says, if you're not at the table, you're on the menu. And so you need to be at the table, even just little bits, like you said, building momentum and education. And if everybody does a little bit, it carries a lot of weight over time.
Well, thank you so much for this fantastic conversation today. Many thanks to Dr. Busby as well as our listeners. You will find the links to the papers and programs that we discussed in the podcast of this episode. If you value the insights that you hear from the JCO OP Put into Practice podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts. I hope you'll join us next month for Put into Practice's next episode. Until then, I encourage you to read the rest of the articles in the special series on the Business of Oncology Practice.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.